So I'll break it down into a couple of areas. One is adding systemic agents to the therapies we already tend to give, which is generally platinum-based chemotherapy. And we had a number of abstracts that looked at this. The two that were presented related to the addition of a targeted therapy developed by Boehringer Ingelheim, which is a targeted agent that looks at targets of VEGF receptor, FGF receptor, and platelet-derived growth factor receptor. So it's a triple targeted agent, and in this case given in combination with cisplatin and gemcitabine, looking at relative response. That was a randomized phase 2 study where the patients either got the tyrosine kinase inhibitor or not, and everyone got chemotherapy. There was improvement in the endpoint of major responses measured by P0 rate or complete response rate when the combination was given. There was modest increase in the toxicity when we added the targeted agent to chemotherapy, and we need further outcome data from this study before we move this forward. But it looks like it's hit its original pre-described endpoint, and so there's a recipe here potentially to move that combination forward. Another study presented by Dr. Shilpa Gupta looked at the addition of the immune checkpoint inhibitor nivolumab to gemcitabine cisplatin chemotherapy. It also showed significant improvement in response for the combination versus the standard arm of gemcitabine cisplatin, using a slightly different endpoint of response to less than PT1. So from that perspective, this also could be promising. This combination has been looked at in other populations related to molecular characteristics such as DNA repair alterations, and we'll see data on that probably in the next 12 months. So this was interesting. And then finally, a very interesting presentation from the German urology group showed that a second TURBT is prognostic when we give intravesical therapy. This has implications for the way we treat neoadjuvantly, because the second TURBT is not always routine and may influence the endpoints that we've been using as surrogates, such as complete response, P0, or a PT less than 1.